So it's a real pleasure to give some basic science research updates to this group today. I just wanted to start by framing the question, why do we pursue fertility preservation as a group? And there are several reasons. One of them is because our professional societies are now at the point where they highly recommend it. So there's enough data to back this discussion, and that the American Society of Clinical Oncology, the American Society for Reproductive Medicine, and the American Academy of Pediatrics even recommend a discussion at least about fertility preservation for both male and female patients who are undergoing gonadotoxic treatments. And we know the second main reason why we pursue fertility preservation is because our cancer survivors have asked for it. They really want it. So 75% of young adults who are childless at the time of diagnosis report a desire to parent in the future. They also describe to us some PTSD symptoms that could be related to infertility as long as 10 years post-treatment. Parents also want fertility preservation options presented regardless of their infertility risk and prognosis, and this is information that we're now just collecting at Lurie Children's and is presented in a poster here at this meeting. And we're very excited to learn more about the patients' and providers' perspectives on fertility preservation, especially in our pediatric cohorts. And so Oncofertility's main focus at the very beginning, as Teresa had mentioned, was the kids that are and adults who were diagnosed with cancer. And so with the increased survival rate because of these life-saving procedures and treatments, we're now really considering the quality of life after they survive. And so we know that survivors are significantly more likely to be infertile or have difficulty getting pregnant than their siblings, but there's also other gonadal dysfunction from genetic causes that could benefit from either fertility preservation or some restorative treatment. And that's really the main focus of a lot of our research. And so what are our current options? We talked a lot about tissue transplant this morning with Dr. Silver. But the standard of care is still only just to bank sperm or to bank eggs and bank embryos. And so for this population for these patients, they have to be adults. And I just wanted to give a brief overview of oogenesis because this is pertinent to the type of research that we do. And so just to give a quick overview of oogenesis, we have primordial follicles that start and exist in all ages within the ovary. There's a centralized oocyte, or the potential egg cell, surrounded by those supportive hormone-producing, hormone-responsive cells called the granulosa and theca here in green. And after puberty, a female is able to release mature, fertilizable eggs, and this happens every month. It leaves behind a corpus luteum that acts as a secondary sex hormone gland that produces progesterone and prepares the uterus for implantation and supports a pregnancy. However, in children, and the main focus of what we do at Lurie Children's is the pediatric population, they are not able to do this standard of care option of banking eggs or embryos. And so we have the ovarian tissue cryopreservation protocols under IRB at our clinic and at many of the clinics represented here, where we take that cortical tissue and preserve it and hope to use that in the future. And really, it is the most abundant time point in which it is the age at which there is the largest ovarian reserve in these pediatric patients as they decline naturally over time. And a normal woman will undergo menopause between 40 and 50 years old. And so this is because from as much as we know, oocytes are definitely a finite resource. And so any sort of adverse events to this tissue could result in significant oocyte loss. And as Dr. Silber alluded to this morning, this is a much more complicated model than what we have simplified here, but we do know, just for example, that a 12-year-old who receives radiation may eventually go through menopause at 19 and a half years old. And so when we think of that word menopause, we think of older women, and we think of other complications that we see pharmaceutical companies advertising for all the time on TV, things like osteoporosis and other hormone complications. And so this is because our sex hormones affect all different tissues in our body. And I just want to take a moment to emphasize this point, because it's not just fertility that we would want to try to restore when we're thinking of regenerating ovarian function, but it's also the sex hormone function as well. And that's because a detriment in these hormones can lead to decreased bone mass, like I had mentioned, decreased muscle mass, high blood pressure, decreased laxity and wound healing, and decreased short and long-term memory. And so I'm going to move into some of the current states of fertility research that move towards reintroducing fertility, and then describe some other regenerative medicine advances. So this was briefly mentioned by Mary Ellen Pavone, but we are able to isolate follicles and grow them in culture to get healthy M2 eggs, and this is done in Teresa's lab with alginate beads. And so human eggs are able to form into M2 eggs from secondary follicles. We're also able to culture cortical strips and maintain health of primordial follicles, so those earliest of follicles that exist in all ages of the ovary, and grow those to secondary and preantral follicles. And through autotransplantation, we've been able to, there are over 130 reported live births to date, and these provide at least temporary hormones with that first transplant, and possibly, as we discussed a lot this morning, could reintroduce cancer cells. And so we have some NPC tissue that I analyzed as a postdoc in Teresa's lab, and many other people have analyzed at different labs as well, that was taken out before chemotherapy, which is our current standard, and there was clear metastatic disease in that tissue. And so we want to be able to improve the process along all of these points. And so with removal of the tissue, with the preservation of the ovarian strips, and with the restoration of ovarian function. And so can we do this in a safe way, and can we restore fertility and hormones for those without ovarian cells, keeping in mind those two properties of the main ovarian function? And so we set out at Lurie Children's, we developed the Fertility and Hormone Preservation and Restoration program. Erin Rowell and I are co-directors, and we set out these specific research goals. And of course, this was in conjunction and because of the wide support of the Oncofertility Consortium that was started by Teresa Woodruff. And so we lay out these goals, and I hope that we can continue to improve on these in this pipeline. So we wanted to first develop immediate improvements in clinical practice, and I'm going to describe a little bit more of that here. We want to establish the next set of advances through translational research. I'm also going to describe a little bit more of that with the 3D printed bioprosthetic ovary transplant. And we want to support future fertility and endocrine innovations that develop stem cells into sex hormone producing cells. And so I'm going to first talk about restoring both of those functions with an engineered ovary. And I think of engineering an ovary in two parts, and one is the bioactive scaffold, the important organ skeleton that supports the cells that make the ovary, and then of course those cells, the oocytes that provide the fertility or provide that female gamete, surrounded by this granulosa and theca cells that both produce and respond to hormones. And so through many iterations in our lab, which some of you have seen in our advanced technologies yesterday, we decided that we wanted to build a scaffold that had a three-dimensional feel. And the main reason behind that is because the follicle exists in a sphere. For those of you who haven't seen one in person, it is a round ball. There's a centralized oocyte, and the granulosa cells that are supporting it are on the outside, and those connections absolutely need to be maintained in order for that oocyte to mature into a fertilizable egg. And so, like you can see in this picture with the follicle in purple, it is supported by, in this case, an extracellular matrix composite paper that we had made with some material scientists, and we wanted to maintain that feel. So we also wanted it to be mechanically rigid so that it could be handled during implantation, because if it falls apart in the surgeon's hands, that's useless. We wanted open pores in the scaffold for nutrient flow, growth, and so that the mature egg could ovulate through it. And we wanted this, of course, to be bioactive and biosafe. And so we used gelatin as our first iteration of this material scaffold, and because gelatin is derived from collagen, which is the most abundant ECM protein in the ovary. And so you can see here a follicle with the centralized oocyte snug within the pores of this scaffold. And we quickly found out that the through pores of a 90-degree advancing architecture was not satisfactory to this follicle growth. And it was really because the follicles preferred feeling more struts. And so, in other words, it required more strut contacts with the outer cells of that ovarian follicle to feel snug and to maintain that three-dimensional shape. And we're able to see this better here with a rhodamine-dyed scaffold. So the rhodamine is in red. And with the follicles stained in calcine, which is a stain for live cells, you can see that the follicle is spherical within that pocket that we made with the 3D printer. Over culture, that sphere is again maintained with the healthy oocyte in the middle, and this is anchored by the few stromal cells that came along with for the ride with the follicle that we seeded into these scaffolds. So the first thing that we wanted to test was whether or not these follicles could mature and release an M2 egg in vitro. And so we cultured these follicles. You can see the same follicle here, triggered with HCG, the equivalent of luteinizing hormone in this case. And it was able to ovulate through the pores of the scaffold for the first time ever in an engineered platform in vitro without any sort of enzymatic digestion. This egg was released through, and it became a healthy M2. And so we were excited about this. And so our next step was to go into a bioprosthetic ovary transplant. To do this, we made sure that both ovaries were removed from our recipient mice. We maintained the rest of the reproductive tract, and we seeded 3D printed scaffolds with follicles. And in this case, I'm going to show you a little bit later, maybe I can skip this, that the follicles are GFP positive. So the reason why we did this was to make sure that we were certain that any pups born of the follicles from this transplant were indeed from the transplant and not from the recipient mice, because we were maintaining that whole reproductive tract and mating them naturally. So these are not stimulated. And when we did mate these mice that had these bioprosthetic ovary transplants, we were able to get green fluorescent pups. So this was extremely exciting for us. And we're hoping, so this also restored hormone cyclicity, and these pups were supported through lactation from the same mom. So a hormone responsive function within this mom was able to support them to adulthood. They went on to have their own pups. So we have 2 generations from this original bioprosthetic. So we're very excited about this, and we're working towards the clinic. So what are the next steps, you might ask? And so I want to bring you back to what a human ovarian anatomy or reproductive tract anatomy looks like in comparison to the mice. And so you can see that the ovary in the mice on the right is covered by an ovarian bursa. So we utilized this anatomical situation to be able to remove the ovary cleanly and put in a transplant and sew that back up right in the same spot. We clearly cannot do this in humans, and so we needed to think of another model for what a transplant site might actually look like. And so we decided to go with pigs for many reasons that I could go through, one of which they have a cycle that's much more similar to humans, a sex hormone cycle that's much more similar to humans than mouse is. And so we decided to use this in addition to the anatomical ratios that are good for our pediatric patients. And so along with Aaron Rowell, wanted to develop some techniques and kind of get our hands wet with this model by really investigating that first part of the flow chart, which is removal of that ovary in the best way. And so the surgical technique that we currently use for ovarian tissue cryopreservation pediatric patients at Lurie Children's is a no-touch techniques. That's a whole unilateral Oophorectomy. That's severing the ovarian artery at the last moment with an ultrasonic energy device. And we pair this about 80% of the time with a common anesthesia used for another reason. So we don't want to have to anesthetize our pediatric patients more than they need to. And so we pair this with another procedure. I just want to remind you that children's ovaries are very small. They're about 1.5 by 0.5 centimeters. And our surgical fellow, Christine Corkum, has recently published a paper reviewing 22 publications for operative approach of ovarian tissue cryo for pediatric and adolescent patients, and found that there is a wide array of techniques used across different sites and even within the same site. And so we thought that it was a good time to develop some standard of care and some best practice techniques. There's even a risk of complications with sharp dissection. If you're asking yourself, why do we even use an energy device, this is one of the main reasons, and that's because there's been a reported incident of intraoperative bleeding, and this is just absolutely unacceptable for a pediatric patient. And so we moved to the Piglet model to establish optimized surgical removal of ovarian tissue while maintaining tissue health. And we wanted to assess ovarian tissue health procedurally with these variables. So we were looking at distance from the heat source, the ultrasonic heat source, and looking at warm ischemic time. So time from the ovarian artery cut to the cold media. And so we wanted to also assess the anatomy for future transplant sites. And so this is really a work with actual pediatric surgeons that do these procedures and have these skills to do the laparoscopic surgeries. We wanted to mimic exactly what happens in the pediatric OR. And you can see Kelly Kelly taking notes on our animals as it's going. This is Aaron Rowell and Christine Corkum, and then it's immediately moved into the lab where we process the tissue. And so this is just an example of what the laparoscopic oophorectomy looks like in pigs. You can see that the ovary is surrounded by the oviduct fimbriae, so much more similar in pigs than in mice, where this is pretty equivalent to the fallopian tube. And you can see the ovary underneath that here. So this is an example of our close dissection. So we're dividing the mesovarium and the ovarian pedicle with this harmonic shear, and you can see that the burn radius is actually coming across to the ovary. And as Dr. Silber very clearly pointed out this morning, that outer area of the cortex is the tissue that we want. And so that's why this is a major concern and a motivation for developing these best practices. We also do a FAR dissection that we make sure the heat source doesn't come within 2 centimeters of the ovary. And so you can see us measuring that here, and then dividing the uterine horn, which is pretty similar to what a fallopian tube arm would look like in the human. And then the mesovarium is cut here, and you could see the ovary kind of protected by the fimbria here. So we assess the ovarian tissue health. We try to do this in a very standardized way. We didn't want to just look at follicles. We wanted to look at the overall tissue assessment to see if these were patients that we were able to transplant this tissue back in, how healthy is that tissue from this technique. And so we used a Sadie Riggs tissue slicer, which slices the top 0.5 millimeters, and we then used biopsy punches to make uniform pieces. We cultured these for 6 days, and what we plan to do is follicle counts, proliferation versus apoptosis, and metabolic markers. I have some preliminary results to show you here. This is what a biopsy punch looks like in culture, and it actually looks and behaves very similarly to what I did as a postdoc in Teresa's lab with human ovarian tissue. They develop these spheres over time, and even though you can't see the follicles in this, you can see that there are clear follicles through the sections. And so, again, I'm using this calcine as a live stain picked up by live cells, and you can see that the tissue is still very healthy. You can even see a large antral follicle clearing in the centers of these spheres. And again, at day 6, if you look at histological sections, there are still a lot of primordial follicle clusters within this, so we know that our assessment overall in culture could be valid. When we first validated this procedure to assess ovarian health, we looked at estradiol, and we found that it did increase over time, and these were in adult animals. But because we are trying to assess laparoscopic oophorectomy in pediatric patients, we actually, it required us that we use smaller, younger animals in our pigs when we actually did these experiments. So what we found was, interestingly, even in the control, the estradiol production did go down over time. They might not have been able to be triggered by the FSH in the media yet, is our hypothesis. But I think the takeaway from this graph is that there is a significant difference across the board, even in the ovaries that we took with the FAR dissection technique. Additionally, we looked at metabolism because, again, I'm also considering the stromal population within the ovary. And we saw that glucose was consumed differently among the groups, especially further out. And that lactate was also produced more so, especially when compared to glucose consumption in the tissues that were taken at close range. So we saw that this increased over time, and this is just preliminary. Our initial results are that this will continue to be more significant even at day 6. So we're seeing that there are differences in the tissue health in this short-term culture by these techniques. And so one of the first things that we're going to do is to test other ovarian tissue removal techniques and to see if we can develop some best practices now that we know this. We're also going to develop the bioprosthetic ovary in larger animal models, and so we're going to be using the pig as a model. And we're going to investigate mechanotransductive cues of scaffolds to inform sustained function of bioprosthetic ovaries. And I'm just going to take a few minutes to elaborate on that last point a little bit. So our next steps in developing mechanical regulation of folliculogenesis goes to this hypothesis that the cortex is, or this knowledge that the cortex is more rigid on the outside where the primordial follicles reside in comparison to the medulla where the growing follicles exist at the center. And we know that, for example, polycystic ovarian syndrome patients have a stiffer, I don't know why this is doing this, but have a stiffer, through MRE, have stiffer ovaries than their control animals. And we think that this contributes to their disease of having a larger primordial follicle reserve, but not as freely growing follicles. We think that the reverse side might also be true, and that premature ovarian failure might be the result of less stiff ovary, mimicking the medulla region in the entire ovary, which might recruit more growing follicles and then deplete that follicle reserve quickly. And so because we know this, we wanted to identify the extracellular matrix composition in the different ovarian compartments. And this is going to be on a poster that my graduate student, Nathan Henning, is presenting. So what he's doing is sectioning through the ovary sagittally and cranially, decellularizing this ovarian tissue, so removing all of the cells, and what remains is the extracellular matrix with the extracellular matrix associated proteins. We're using Northwestern proteomics to analyze each of those strips and coming up with basically a heat map or cube that it would be nice if it would be the shape of an ovary that basically maps where the extracellular matrix components are and how it relates from the cortex slightly in all the way to the center medulla region. And so this is just an example of some of our preliminary data with collagen 1A1 and how it differs from the different regions that we've analyzed so far. The white boxes are things that we still have yet to fill in. So stay tuned. And just to close, I just wanted to mention that we are really excited to be partnering here since we're very close at Lurie Children's to Northwestern. That we have 6 posters representing our group here, including the ones that I've mentioned, but others with surveys and operative techniques, ECM composition, which I mentioned, and even a little more detail about our pig surgeries. So I invite you to visit all of these posters. And with that, thank you.
First, wonderful presentation. Congratulations. I think we could be here the entire day talking about that. This is a wonderful work. I was thinking when you have the scaffold and you put the follicles on the places, you put like one individual follicle or a group of follicles or a piece of tissue on each of the places.
So in the experiment that we did, we were considering that there might be, we wanted to use a protocol where we isolated the follicles in consideration of the potential of having cancer cells present in that tissue was our mindset. And there's been a few labs that have shown that if you go through washing techniques, you can remove those cells. The metastatic cells and isolate the follicles. So we were using isolated follicles with that idea and seeding them individually into the scaffold.
And are they secondary or primary?
All of our preliminary all of our results setting up the bioprosthetic ovary were defined by secondary follicles, because in mice those were the easiest to do and what we knew the most about with the alginate experiments. But when we did the bioprosthetic ovary, we used smaller follicles.
And another question. You put them using like a buffer solution, the regular buffer solution, or do you put some ingredients, secret ingredients to help them?
No, we used no secret.
Like
all
some
of it
hormones?
is on. Yeah, all of it is. This was just published this last May, so it's all there, and it's also from the Follicle handbook that Teresa has posted on the Oncofertility website. So nothing extra.
Thank you.
Yeah.
And more questions?
Yeah,
Hi.
Kyle Owick from Pittsburgh. So the proteomics idea is really neat in characterizing the extracellular matrix in different portions of the ovary.
To listen.
It works
Microphone.
now. So I really like the proteomics experiment in characterizing the ECM in different parts of the ovary, but I think this works okay now. It's fun. Yeah.
Yeah.
But what I wonder also is, are there differences in the cell types in the stromal tissue around the follicles in the cortex versus the ovary, or versus the center part of the ovary?
That's a great question, and we're doing a lot of other experiments to kind of pair that proteomics analysis. One of them is to use immunohistochemistry to localize the ECM that we're finding in our proteomics analysis to see if it's within the stroma versus follicles, and doing that type of analysis based on the sections that we've taken. So yeah, I think that's an important point, yeah.
Anyone else? No? I think congratulations, and let's then move to our next presentation. Dr. José Ricardo Figueiredo from Brazil. He is Associate Professor, Animal Reproduction Section in the Department of Veterinary Medicine at State University of Ceará, Fortaleza, Brazil, and coordinator of the Brazilian Network for Artificial Ovary Studies. So today he is going to talk about understanding in vitro folliculogenesis in farm animals.
Thanks, Jennifer. First of all, I'd like to thank the organizer for inviting me to this very important meeting, especially Dr. Teresa Woodruff. And it's a great pleasure for me to be here to talk to you today about understanding in vitro folliculogenesis in farm mammals. I'm going to cover the following topics. The first, an overview of folliculogenesis regulations in vivo. Then, some basics and applications of in vitro follicle culture and its use as a tool for understanding folliculogenesis, focus on the balance between extra and intra-ovarian factors, influence of extracellular matrix, follicle interactions, stage-specific follicular requirements, and eventually some final considerations. It's well known that mammalian ovaries contain from thousands to millions of follicles, whereby approximately 90% of this population is represented by preantral follicles, which in my definition includes the primordial, intermediate, primary, and secondary follicles. Despite this large follicle population, the vast majority of them will be eliminated by a physiological process named atresia during folliculogenesis. Folliculogenesis is the physiological process in activation, growth, and maturation of the ovarian follicles. We define follicular activation being the transition from primordial to growing follicles. Doesn't work. Okay. The regulation of folliculogenesis involves a complex interactions among endocrine, paracrine, and autocrine factors, which in turn affect steroidogenesis, angiogenesis, basement membrane turnover, follicular atresia, oocyte growth and maturation, as well as the proliferation and differentiation of follicular cells. Folliculogenesis is a such complex process because follicles in the ovaries are under influence of many extra and intra-ovarian factors. To make matters worse, many of these factors share the same receptors. Also, there are complex interactions among cell signaling pathways that eventually control gene expression, which determine cell survival or death, quiescence, or proliferation. Therefore, follicular fate in vivo, atresia, or ovulation depends on a fine balance between stimulatory and inhibitory factors. It doesn't work. After this brief overview, it's reasonable to state that understanding the control of early folliculogenesis is crucial to optimize the use of ovarian oocyte reserve in assisted reproductive technologies in human, as well as in other mammalian species. Among these technologies, I will highlight in this presentation the in vitro follicle culture. Now, I'm going to give you some basics and application of these technologies. Oh. Go back, please. What's going on? No. I'm sorry.
Is this one?
Go forward.
So
You need to
use
change
this
it?
one. No.
It's okay?
You can still use the laser pointer on that.
No, it's okay.
But
Okay.
advance.
Okay. In fact, taking into account that the vast majority of follicles in the ovaries will be eliminated by atresia in case they remain in the ovary, the ultimate goals of in vitro follicle culture are rescuing prenatal follicles from the ovary before they become atretic, being able to culture them up to maturation states for the purpose of preventing follicular atresia. The aim of this technique is to mimic what happens with a few follicles that escapes from atresia during the folliculogenesis and ovulate. Then we also name this technology artificial ovary. This technique has some future and current application, such as study the control of early folliculogenesis, complement other reproductive technologies, create gamete banks from endangered species and breeds, preserve the fertility in individuals subject to cancer treatment, human fertility treatment, and also aid in studies on reproductive toxicology. Goats, the many species I work with in Brazil, are considered a good model for human due to the similarities in terms of ovarian size and texture, as well as they share long-term folliculogenesis, approximately 6 months. In Brazil, we have successfully used goat in vitro follicle culture to perform toxicity tests of anti-cancer drugs for use in human, such as doxorubicin. Basically, there are 2 ways to culture follicles in vitro, in the isolated form or enclosed in ovarian tissue. We name this in this presentation in situ culture. Isolated follicles can be cultured either in a 2-dimensional system which means the follicle is placed on the plastic, which may be a plastic or an extracellular matrix, such as collagen, or in a three-dimensional system enclosed in an extracellular matrix. In situ culture, on the other hand, can be performed using an ovarian slice or the whole ovary. The efficiency of in vitro follicle culture can be evaluated using the following parameters: follicular survival, follicular activation and progression through folliculogenesis, oocyte and follicular growth, hormone production, gene expression for key factors, ligands and receptors, entry formation, production of full-grown meiotically competent oocytes, and we can also evaluate oocyte developmental competence through the production of embryos and live offsprings. It's important to emphasize that, the production of live offsprings from primordial follicles cultured in vitro has been only achieved in mice, and it was first reported in 1989. In order to develop an efficient culture system for caprine preantral follicles, since 2006, we have been working a project named Artificial Ovary. In this particular project, the effect of more than 30 factors in different concentration, association, type of culture system, culture addition time, and culture duration are being tested. In the next slides, I'm going to share with you a few protocols and results from this project. Now, I'm going to show you the use of in vitro follicle culture as a tool for understanding in vitro folliculogenesis using the GOAT model. Let's get started with the GOAT, primordial follicle survival and activation. To study this, we have been using the in vitro culture of caprine preantral follicles enclosed in ovarian tissue. Basically, ovarian tissues from slaughterhouse material have been cultured for 7 days at 39 degrees Celsius in 5% CO2 in air in a modified minimal essential medium. This table summarizes the main results of the test. As you can see here, the addition of all these factors individually to a control medium improved significantly in a concentration-dependent manner follicular viability, activation, and growth. Similar results have been obtained using preantral follicles from cow, pig, sheep, and mares as well. It's very similar, in fact. As you can clearly see here, many factors improve the same endpoint, which can be explained by the fact that all these factors will end up controlling gene expression, which determines follicular fate. Now, I'm going to show you an example of long-term in vitro culture to develop sequential media. In these protocols, ovarian fragments were cultured for 16 days in a control medium or control medium supplemented with 2 factors, A and or B, added in the first and or second half of culture, resulting in 10 treatments. Just to give you an example, we tested the combination of FSH and GH, or GDF9, or KL.